Happy to have a group of people here today to listen to our incredible speaker. Thank you for those that are joining us online. This is our first Lunch and Learn of 2025, and we have more to come. So looking forward to having you all here to focus on some global nursing. Hi, Kim. She was in our class this morning. We launched our certificate program this morning. So I would like to start by warmly welcoming one of our favorite ladies and nurse leaders around the world. I wrote some things down because I don't want to forget, y'all. Dr. Edris Malata is gracing us today with a talk about nursing and midwifery in Africa with a focus on her home country, Malawi. She serves as the Vice-Chancellor of Malawi University of Science and Technology, where she has made history as the first woman to hold this prestigious role at a public university. Beyond her groundbreaking leadership, Dr. Malata is a distinguished figure in international nursing and midwifery organizations. She's widely recognized as a powerful speaker, accomplished author, although I'm still waiting for her biography, which you will all want to read when that comes out, and tireless advocate for women empowerment. In addition to her many achievements, this year, Dr. Malata is the recipient of our 2024-2025 UCSF Presidential Chair Award, serving as a distinguished visiting professor in the Department of Epidemiology and Biostatistics here at UCSF. In this role, she's leading efforts to develop an engaging and innovative bidirectional graduate degree program that promotes equity and understanding in global health education. Her work bridges UCSF, Malawi University Science and Technology, and other global partners to create an impactful collaboration to advance healthcare across the globe. Today, Dr. Malata will share her expertise and insights on nursing leadership and global health, and I am so honored to welcome her today. Please, a round of applause for our incredible speaker.
Thank you very much, Rebecca, for your kind introduction. I also want to recognize in the room Professor Sally Rankin. Where is Sally? So I first came to this institution because of her. I think a great leader in nursing and well known in my country, not just Malawi, but I do think Africa. Please give her a round of applause. Thank you, Sally. Thank you. And of course, also, in our culture, we normally do this, also recognizing Kim. Kim, where are you? Is Jenny here? Jenny. So these are all colleagues of mine and that have made this possible. The reason why I'm standing before you today is because these nurse leaders have worked with me. And of course, Jane Liu is just walking in. She's not a nurse, but also a very close friend of mine, a fellow professor here, and then a colleague in our family planning studies. So thank you, Jenny, as well. So want to appreciate this opportunity that I'll be able to share with you my journey of nursing and midwifery in Malawi. And I think this presentation is just happening at a very critical time, I think, globally. We all know what is happening. And so this is what I want to talk about. Seems quite a lot, but I'll try to be very fast so that we can have a time just to have a conversation in case we have perhaps students that may want to ask questions or even our fellow colleagues here that may have questions. So I know, and I think most of us who are nurses here know that we are the heartbeat of the healthcare system. And I do know that people talk about the backbone, but my journey as a nurse over the decades, no healthcare system in the world can exist without nurses, midwives. They are core. They're very important. And I do know that when you look at any country, when you look at perhaps even the rating for nursing and healthcare, not always at the top, even in financing, we don't get all the resources. But whether people like it or not, no healthcare system can exist without nurses and midwives. So my daughter is a medical doctor and she's around with me. I wish she was here so I could challenge her, or she thinks that they are more important. So I do like this quote. The World Health Organization resolution 64.7 says, recognizing the crucial contribution of nursing and midwifery professions to strengthening health systems, to increasing access to comprehensive health services for the people they serve, and to the efforts to achieve internationally agreed health-related development goals and those of the World Health Organization program. So there's a resolution. So at WHO and all other international organizations, the recognition that nurses and midwives are very important, on paper that exists. But whether this really translates into what happens in terms of financing and support, perhaps is something that we need to discuss. We all know that healthcare is a human right, and there's no debate about this. Every individual deserves good healthcare. And of course, we also know that there's a linkage between healthcare and poverty. So if you have a poor community, chances are high you are going to have many healthcare problems. And then, of course, I said earlier on, health is about nurses and midwives. And of course, survival is linked to a number of health workers. So where you have many health workers, there's going to be survival. Fewer health workers, you lose many people. And I think this graph here shows clearly, and sorry for I think a typo on maternal survival. My daughter noted it yesterday. It's like, Mom, you need to sort this. So maternal survival, child survival, infant survival, you actually see that the more health workers you have, the more people are going to survive, the more children are going to survive, and then the more infants are going to survive. Now, what is the status of global healthcare worker crisis? So WHO estimates that we have globally 65 million workforce, but of course an estimated shortage of 10 million midwives, nurses, doctors. That's what we need by 2030. Over 57 countries, and most in sub-Saharan Africa, have critical shortage. And of course, just for sub-Saharan Africa only, we need 1 million health workers to bridge the gap. And we also know sub-Saharan Africa holds 25% of total global health disease burden and only 3% of the world's health workers. The countdown countries have adequate number of personnel, only 4 of the 73 countdown countries. And then we also have a low percentage of health workers, of course, with high global disease burden. I think this is what I've just talked about. This is a very important graph for me because it actually shows, you can actually see, I don't know whether I have a pointer here, but you can actually see that Africa has got the highest global disease burden. So at the time I took this, was about over 15%. Now we're even at 25% according to the data I saw yesterday. And yet when you're looking at the health workforce, the lowest. So actually you see that I think what's happening here should actually be the opposite. You have very few health workers, and yet when you're looking at this disease burden, now, as of yesterday, this has shifted to 25%. And I think for nurses and midwives, we need to be worried because this should not be happening in this century. I also want to share with you critical shortage. So when you look at the dark, is it orange there, shows countries where there's a critical shortage. And then, of course, the other one is where there isn't much critical shortage. But when you look at these dark places here, dark orange, you actually see that Africa is one of the countries that's got huge challenges with the numbers of healthcare workers. This is the same information presented in a different way. World distribution of health workers. So this map is an approximation of actual country borders source, which is WHO source, and this is according to the World Health Report 2006. And you can actually see it's the same thing, that where we have very few workers, we also have the same issue. happening here and here. Very, very important information. Now, in terms of nursing, midwifery personnel, you can actually see also what's happening in Africa. And then Americas here, that's where you are. Europe, Southeast Asia, Western Pacific. So we have the density of the 100,000 population of health workers, and see what is happening within our countries. So issues of nurses and midwifery workforce have always been a big issue. Now, coming to Malawi as a country, so Malawi's healthcare system has got a healthcare sector strategic plan, now number 3, 2023 to 2030, so not 2020. And this is a roadmap for Malawi's healthcare system to achieve universal health coverage. And the focus is improving health service delivery, addressing social determinants of health, strengthening infrastructure, and developing human resources within the healthcare system. There are still challenges because of issues of availability, quality, access to services, including environmental and behavioral issues. And of course, there's always been issues with implementation of the health sector strategic plan. And I did my own study, although it's in 2012, still reality now. The results of my study are the same. The numbers, the quality of care, resources not being available in our healthcare system. So for Malawi, nurse and midwife population ratio is at 1.2300, which is below WHO. WHO recommends 1,000. And then, of course, we have approximately 11,000 nurses and midwives with only 50% in clinical setting. This is very important because when you look at the numbers of nurses, you might be thinking, oh, the nurses are there. But count those that are on the clinical side in communities, 50%. And then, of course, vacancy rate for nursing and midwifery positions in public sector is over 54%. When I first did my studies on nursing and midwifery in Malawi, we were at 75, now 54%. But 54% is not small. This is still significant. And of course, in terms of geographical distribution, 74% are in urban areas and only serving 19% of the population. So 19% of the population is what's being served. So the numbers are there, but the nurses are in Lilongwe, if you know Malawi, Blantyre, Zomba. They are not in rural Mulanje, they are not in rural Palombe. This is very important because somebody can just look at the numbers and think, wow, 11,000, but where are they? And why are they in town? They want a better school. In the rural areas, not every village has got electricity. So nobody wants to keep their children in a rural setting. They'll all be pushing to go into town. And it's still happening now. It happened 40 years ago when I started my profession. It's still happening now as I speak. And I know that Sally, Kim, Jane, those people that have been to Malawi will agree with me that that's what they see on the ground. So we'll have time for people to ask questions, but let me move quickly. So I wanted to share with you what are the challenges. So those of you that were listening to me last week, I like the big 5. I just changed the way they look. So today I've got another big 5. So I group our issues for nursing into 5 issues: nursing practice, nursing education, nursing research, public image of our profession, and of course, issues of governance and leadership. So I'll try to move through them quickly. So for public image, like in many parts of the world, it's gender factors. We have many women entering the profession. Of course, for Malawi, we've seen a shift. I think a good number of male nurses now in our profession, but we still have issues of acceptability. And then it leads to salaries, because this is a profession that's predominantly a female profession, so you cannot argue for salaries. Actually, if you are a woman and you are a nurse, people look at you, even if you have a PhD, they always think that your PhD is a lower PhD than someone who is actually an engineer. And I studied in Australia, master's, PhD. When I went to Australia and I was in the same class with engineers doing research courses, I think my confidence went up. And during graduation, I was the only nurse and I had these engineers graduating with me. When I was appointed Vice-Chancellor, there were questions about what is this nurse going to do? But today, my university is the #1 university. And I've been able to navigate engineering, information technology, geoinformation systems, everything about science and technology very well as a nurse. So as you heard, first woman to be a Vice-Chancellor, but the first nurse to be a Vice-Chancellor in Africa. It's never happened. I broke the record. The second nurse was appointed a year ago, and it was in Ghana. Actually, Ghana government reached out to me to say, we're appointing a nurse like you. We need to reach out to you so you can have a conversation with this nurse. And we just met, I think like 2 months ago in another meeting. I was excited to see another nurse who's a Vice-Chancellor of a public university. It means you are the president of the university. My boss is the head of state. So I report to him directly. That's how powerful the position is. But for me, it is about nurses getting into those low leadership positions, that you are making decisions, you are shifting. You know, you can actually stand anywhere in government and speak and people will listen to you. So now there's respect for nurses in Malawi. And I've seen now other nurses taking leadership positions, and I would want to see that happen in my lifetime so that the public image must change. Nurses are good, they can do anything. They should not be looked at as a lower or a junior profession. And so, of course, here I'm talking about access to education for the girl child. Not easy for a girl child in a country like Malawi and many other countries in Africa to go to school and stay in school. Nutrition, menstrual hygiene, support. I went to school without shoes. And I was telling people over lunch on, I think the other day, we were invited by one of the colleagues here. I said, my daughters don't believe the story because they can't imagine that as their mother, I went to school without shoes. Girls struggle in Africa, and particularly in Malawi, we have a lot of challenges. And of course, opportunities for growth. Remember, I talked about going to Australia. The time I finished my BSc program in Malawi, there was no master's program in Malawi. So every nurse in Malawi had to leave Malawi, either to come here, to go to Australia, to go to the UK. And I went for PhD studies with a baby on the breast, 10 months old, and she's here with me. I wish she came today. We should have brought them here. 10 months old, on the breast. And I left a 2-year-old, Esther, with her dad. And when I finished my studies, I was determined I go back to Malawi. I must introduce postgraduate programs. Not every nurse must leave our country. If people want to leave, they must leave because they have an opportunity, but not forcing you because you have no other option. And you can't have a voice if you don't have PhD prepared nurses. You don't have master's prepared nurses. They need to have a voice, but they need to be prepared for roles they can take in the nation. And of course, second issue about disease burden. Remember, I talked about the fact that we do have a lot of challenges. And this is global. It's not just Malawi. But I think for Malawi, what I wanted to share with you is the fact that the double disease burden, communicable diseases, non-communicable diseases. I think what I'm showing there, when I did this, it was actually showing like we have a lot of communicable diseases. But this has shifted. I was looking at that as well. Is shifting because we're having now many people suffering from, hypertension, diabetes, which was not the case 30, 40 years ago. And I know it's about lifestyle and many other issues. And you can see the same picture for Zambia, our neighbor, Mozambique, our neighbor, and Tanzania. So I do countries that are very close to Malawi and, of course, Africa as a region. Maternal mortality, women dying whilst giving life. Huge issue, and as a midwife, this is where my heart is. But the good news is that we have had a very good trajectory, really moving down. We had a lot of women dying. If you can see there, I think this is in 1995, and then you're coming down to the 205. You can actually see that we've really been going down. And I think our target projection was that we'll be at 435 before 2020. which has really happened. So you can actually see now, as of today, we are 381 per 100 live births. But this is not good enough. No woman must die whilst giving life. When you look at the reasons why these women die, it's about infection, they have been delayed, perhaps they were in a village somewhere, they were not able to go into a hospital. And I tell a story myself that I had finished my PhD studies 2004, going back home. I got a grant. A friend of mine from a university here contacted me that we should do a study on quality of healthcare. And it was a colleague at Johns Hopkins University. So we went into villages in Malawi to find out why women died. This particular story breaks my heart because we went to a home, we found this woman who told us a story about their daughter. And what she said to us was that my daughter was healthy, she was pregnant. 9th month, we went to the healthcare center, health center. We arrived there and we were informed that, okay, this labor is prolonged. So chances are high that she might require cesarean birth. You need to go to a district hospital. But we were waiting for an ambulance. And this woman said for 2 days, for 8 hours, they waited for an ambulance. And then ambulance came, she arrives at the district hospital, she died on arrival. And she told us the story that she could still see the baby kicking, and she asked the midwives if there's anything they could do. And the midwife said, nothing, we can't do anything. And so she said, I went into the labor room, went out, went back, and then eventually I couldn't see the baby kick, and my daughter had already died. So she posed the question to me that when my daughter was waiting for an ambulance, we waited for 2 days. My daughter died. Immediately there was an ambulance to take us back to the village. And I broke down. As I said, in the 21st century, that should not happen. And the sad part of this story was that the husband of this young woman was still waiting outside. He says, this man has been here 6 months after we buried my daughter. He hopes his wife will come back. So since that time, I decided I was going to fight for maternal mortality. Women must not die. And it's not fair for a woman to be waiting for 48 hours for an ambulance, and then when something happens, then an ambulance is available. So whether it's a system, whether it's availability, whether it's decision making, I was determined that I should teach my students well. This should not happen. Cry for an ambulance, even if it means getting an ox cart to get that woman so she can have a cesarean section done on time. So big issues there. So in terms of nursing practice, the quality of care is a big issue. Remuneration and lack of incentives of those nurses and midwives, another big issue. Migration, internal migration. So the nurses don't always leave Malawi. They will be in Malawi, but they will be working for UNICEF. And I do know that people say, oh, well, they are within the country. Yes, they are within the country, but they are not on the clinical side. So we need to train more, but when we train those nurses and midwives, they must be employed by both government and also international organizations. So internal migration, people don't discuss it, but for me, in my 30, 40 years of experience, this is a big issue. Internal migration and of course, external migration. So a lot of nurses leaving Malawi. UK is where they like to go, and of course, some in South Africa. Some countries are difficult to penetrate, but we've actually seen a lot of movement. If you ask me, is that okay? It is okay. Because if you don't employ them, why should they be trained? And then they have children. Some of them are widows, some of them are single parents. They need support, they need something. But what is wrong is the fact that if we deplete our system without an alternative, because it means those we have trained, we must recruit them. And many times governments in low-income countries have challenges. They will push, yes, train, but we don't have money for recruitment. And then when there's no donor support, international support, then we have a big issue. So I've talked about poor remuneration, but also poor working environment. If you go into a labor ward in our country, a labor ward perhaps in Uganda and Ghana, you see a difference with a labor ward in a good hospital here. And there are people, there are nurses who, well-trained, eventually decide to leave because the work environment is quite overwhelming. You may see blood everywhere, and perhaps nobody's cleaning, and perhaps those who are cleaning are supposed to be taking somebody who has died to a morgue. You know, a lot of issues. When I started my nurse training, I think in third year, I nearly gave up. And the reason was because on a night duty, I went to the ward. There were only two of us, a trained nurse and myself as a third-year student. And we started giving medications at 2 a.m. for 6 a.m. because there were many, many patients. And so the nurse asked me if I was comfortable with starting to give medication or I should take a dead body to the morgue. And I preferred going to the morgue because I wasn't sure about giving all medications. And so I was with a cleaner, the two of us, pushing in the night. We arrived at the morgue, and the morgue was a very small room, dark, no electricity then. She needed to collect keys so we could open. So this cleaner asks me, do you want to go collect the key or you stay here? And as a student, I thought, wow, I don't know the key. So I said, I'll stay here. And so in the dark, in the night. And she goes for some time. I don't know whether she delayed deliberately. And then she comes back with the key, and then she opens, and then she tells me the two of us must lift. And we're lifting there, and we're finding bodies of people that had died in the night, brought in by police. So that next morning, I thought I was not going to make it. And I went to our principal then was a Canadian. I said, I think I'm not a good nurse. I won't make it. And she said to me, it'll be all right. Just go sleep over it, you'll be fine. But I have never forgotten. It's many years ago, quite overwhelming. So imagine the nurses that are on the ward that see all these things every time, many of them eventually will drop off. And then, of course, there are issues of negative attitude and burnout. And I did a study with a student from Norway, and we actually found that nurses were overwhelmed and overworked. Sometimes they finish at 6 in the morning, they stay, do another shift the whole day, called locum. Not good for the profession. They're physically very tired. And then, of course, issues of critical shortage, which has been one of my passion. Numbers. So this is just showing about the community health nurses. I tried to break this down to nurse technicians, nursing officer, psychiatric nurses, and this is really about the numbers and the shortage. So perhaps we could skip that for now. So what about education? We have made progress. And I've used my old papers deliberately, so because these are studies that I've done. And then, of course, there are inadequate resources for theoretical and clinical teaching for both faculty, infrastructure, clinical sites, cases. When I did midwifery, I had to at least assist 100 women give normal birth, SVD, as we called it at that time, and then 6 breech, 6 vacuum, before you graduate. Today, our students don't have cases. They have to run medical doctors. That time there was no medical school. So we had everything to ourselves, but now we have medical students and other programs. So the numbers are big. But maybe a very important point I want to raise here is about quality versus quantity. So we've been pushed, get as many students, get large numbers. So all colleges of nursing in Malawi, large numbers. But my question is the quality good? Because when people are now complaining about they're not as good, is it about the numbers? Are they getting the attention we got because we had somebody, perhaps if you were just 30 of you, you have 6 or 7 people teaching you, it made sense. Now our intakes are over 100. And then, of course, curriculum overload. Nursing seems to be a soft ground for any changes. So when there's something new, change the curriculum. Sometimes it comes even at the international level, add this, add that. No one tells us what to take out. And because we protect the profession, we also know there are basic element issues in the nursing and midwifery curriculum that need attention. And we want to make sure that we keep them in. And because of that, curriculum overload. And of course, I wanted to talk about issues of internationalization, globalization, things happening. So you are trying to copy what's happening in the US, what's happening in the UK, and then everything starts, changing. The way I was trained is not the way the nursing students of today are trained. And of course, through educational progress. What am I talking about? I will not take much time to explain. But it took me 13 years to get a PhD. So it's school here, school there, school here, school there. And I'm adding the years. I started diploma 3 years, midwifery 1 year, advanced degree now for basic education, for nursing education, another 2 years. You want to go out for a master's, another 2 years. You want to go out for a PhD, 3 years. And then in between there are gaps. So for me, 13 years. I am determined, and I've been pushing that we shorten the time. Because otherwise we will not attract as many. If a student asks me, how long did it take you to get your PhD? 13 years. How many are going to come to that profession? Very few. So we must find ways, and I've really been an advocate for changing and perhaps having students do things in a shorter time rather than thinking that everybody must be there. Now I want to talk about regulations. Our nursing and midwifery regulation in Africa, and particularly in Malawi, is actually established. We have standards. Although our legislation has not been revised to suit current trends and practice, but at least something exists. Because I have been a president for nurses in Africa. And so I know many countries in Africa that at the time I was president did not even have legislation. So members of parliament don't even know what is happening about the profession. What is key now, I think, like for Malawi, is that they protect this. Because what's happening now, there's a lot of combinations. So like our College of Nursing, where I was head of school, is now combined with the College of Medicine. And so already you can actually see that we could be losing power if you're not careful. Actually, I'm thinking I need to go back there. Because I do worry that the nursing profession may eventually disappear. And that should not happen because we do work together. I even introduced a program in interprofessional leadership at PhD level because I do believe that all professions are important and people should learn to coexist and also learn together. Regulation, although existing, it has been waiting for revision. So it's about the issue of merger. Remember I talked about nursing and midwifery. So people think, let's just combine everybody in the healthcare system. There should be one grouping, and people are still arguing. And then, of course, I do say that regulation, depending on educational institutions, may influence independence. So it depends on how powerful you are to make sure that although you've been combined, but you still have your space. We also have professional organizations, very important. So we have a midwifery association, and I served as president at some point, and then we have a union for nurses. And for the first time, Malawi has seen nurses putting down their tools because they want better, environment, they want better pay, and put pressure on government. And as you know, usually before they do it, then government steps in. There will be meetings at the ministry and the president and trying to meet these people. But at least it has also helped, although sometimes people think negatively about it, but I do think it has also still helped nurses to have a voice. Although what happens in our political system is that those who make that noise eventually will be given positions elsewhere, and then they are comfortable and they no longer make noise. So, well, it's politics. So there's need to strengthen the link between unions and regulation because at the moment they work as enemies. They don't want to hear each other's voices. One group is protecting its entity, so I've always been thinking they need to talk together. And also there's need for further development of these organizations to further promote nursing and midwifery professions. For me, it's about them knowing what to do, what to say, and how to push their voice on that table. How can they get into State House? How can they persuade the head of state positively for the sake of the profession? Moving on, and I'll be finishing shortly. Nursing and midwifery research, there has been development, still limited capacity. And also many of the findings in our research studies not impacting practice policy education. I studied, as I said, for my PhD in 2000, finished in 2004. That's when I graduated. I produced a childbirth education needs for Malawian women. Ask me when Malawi adopted it. Finished 2004. It was adopted 3 years ago. Because people didn't believe that a midwife, a nurse from Malawi could come up with a childbirth education program. So we need to make sure that our research study, so now it's teaching students how can they get policy documents, policy views. Over time, having been a leader, I've learned now how to navigate to get my voice out there. So I do not fear anybody, whether it's head of state. If I need to put up my hand for the sake of the nurse or the profession, I will do that. And many times, even when they have important people, Melinda Gates comes to Malawi, they invite me to State House. And I've learned to put my hand up. A Malawian woman, a Malawian girl is not taught that. You keep quiet. The man must speak. You keep quiet. But I've taught my students, please raise your hand and raise it high. And make sure in bright colors so they see you. And make sure you make that your voice known and heard in that forum. Because you could be saving multitudes. Remember, it's not just about the profession. It's the people we save, the patients, the clients, those women, the children. And I usually tell them, these people will never come to our cities. They are in a rural setting in Lilongwe, maybe in Kasungu, in maybe Chitiba, which is furthest in the northern part of Malawi. They will never come to the US. So if I'm at the UN and I'm at a meeting and I need to voice something about the profession, I will put my hand up and I make sure I do it first, because that voice must get there. And I think what we need to do is to make sure that we make our voices heard, but we teach our students, our graduates in our universities, skills. They know what to do. And then when they are doing research, it's not just being there to collect data for someone. I've told people, your responsibility as a nurse is not to collect data. You can actually ask the question. And I know there are issues about who funds that, but I think when you're pushing your agenda, you get to a point where you can actually be a principal investigator and also do things that you want to do for the sake of the people. So I put a few publications there. I put some of my colleagues. Governance, which is a final issue on the big five: political will, policies that govern nursing and midwifery profession, career progression. Remember what I talked about. Shorter time for medical doctors, longer time for nurses. Can we make sure that nurses are also getting the profession on time? Deployment issues. So you find someone has been trained as a pediatric nurse, and then they say, no, we need to change them. You've trained them, you've equipped them with skills, they will be moved to mental health. And the idea is, I know people should have different experiences, but the moment they are being shifted, it means somebody must be trained again. And then, of course, in-country imbalances, rural versus urban, as I said earlier on. Leadership capacity, we must build leadership capacity at all levels. And really making sure that our nurses are able to make decisions. Even when they're in a district hospital in that rural Malawi, our desire has been they must be able to make decisions. They should not be following. They should be able to make decisions and say, no, this is not good enough. And we've been able to change that. Remember what I said? I studied in Australia. There were very few. Actually, people asked me, why did you go back? I had a sick child. My daughter had sickle cell disease. Why did you go back? There were no people in Malawi. I needed to go back. I needed to support the profession. I needed to push the profession. And it was very important because the moment you start doing that, then you get to mentor other people. And I remember the time I left the College of Nursing, at least I had 60 PhD prepared nurses in my college. And I think we had the largest number in Africa at that point. But the moment you develop them like that, it means they can now start training other nurses. And these nurses now are directors. Our director for HIV in Malawi, director for reproductive health, they are all nurses. You cannot be crying for positions if people are not well prepared. What is the future? I do believe there must be more investment. Nursing and midwifery workforce, deliberate policies, regulation, association, and attracting the nurses to stay in the profession. If we don't attract them, then the issue of migration will still be an issue. They must be trained but they must be given jobs. And then when they are given jobs, they should be paid, at least to be able to pay their own children to go to school. I hear stories of our nurses in Malawi that struggle. They can't pay school fees because they're a single mother. I don't think anybody would want to go into that profession. So I saw one or two of my graduates that finished nursing, then went into medicine. And all they said was, I wanted a better package. And I don't think that's fair. People should be paid for the work they do. So there must be investment. And I think for me, pre-service and continuous education for nurses is the best buy in primary health care. Malawi is a low-income country, but has made progress in nursing and midwifery practice, education, and research. We still face challenges, but I think we're here to solve these challenges. I want to finish with this quote by Ban Ki-moon, and I love it. We need to rapidly boost the global health workforce. Africa alone will require 1 million new health workers. Without such dramatic increase in capacity, immunizations will not be administered. So it mentions many other things. Curable diseases will remain untreated, and women will keep dying needlessly in childbirth. Remember, we are the heartbeat. Any healthcare system, whether people like it or not, nurses and midwives are the heartbeat of that system. Thank you very much for your attention.
We seem to have 10 minutes, which is a great amount of time for people that might have questions for Dr. Malata. What an amazing talk. Thank you so much for sharing. Her life is amazing when you hear all those stories. And I think she got some of my favorite ones in that, in her journey as a nurse leader. Does anybody have any questions? Maddie, if you could check the webinar, but otherwise I'll start with one I have. Oh, I see. Start here.
Hi, Dr. Malata. First of all, thank you so much. That was an amazing presentation. I was just wondering about the 50% number. You said there's 11,000 nurses and 50% of them are not in clinical settings. I was wondering if that's because like the other 50% are, let's say, midwives doing births from home, or is it that they're unemployed, like unable to find work? Like, why is it only 50% are in clinical settings?
Okay, so there are those that can't find work. I think there's a lot of unemployment, and I think Kim, in her work, that's what they have found, that nurses that finish, registered nurses, and then they are not immediately employed. I got employed before I even finished work, but it's not the case now. But then we also have nurses that are doing other things. Then all these international organizations. So if you go into Malawi, USAID is full of nurses, UNFPA, UNICEF. There's no international organization I know that doesn't have my graduate. Actually, the majority of them are my graduates. So it's they are doing other things, and it's about the work package. It's about empowerment, and also at the moment, in my time, I would say it was better pay. But for now, it's also about if they don't get a job immediately after graduation, if another organization has got a job, then they'll get that job.
Hi, I wanted to ask, are doulas common in Malawi? And then also, like, have there been any discussions, like with the associations or any organizations on integrating them within their healthcare system, especially with a couple of the things that you talked about? And then doulas are what I talked about. If they're common in Malawi, they're like, I think they call them, there's another term that they call them, but they're similar to midwife, but in essence, they're not allowed to, they're supposed to not be allowed to perform, to actually like deliver the babies, but they help with emotional support, a lot of emotional support and education on like childbirth education, also like breastfeeding, but even with abortion loss as well. So not just focusing on labor, but also like the full transformative experience of birth.
Yeah, so what we have is what are called traditional birth attendants. But the system, I think WHO made a ruling or a decision that we should not allow them to support. That in the past they used to help women give birth, but we only have health surveillance assistants that normally just help with perhaps taking temperatures and doing other things, bathing patients, but not necessarily doing anything. I think at the moment, what is critical for Malawi is if you have nurses and midwives that have been trained and they have graduated, why not employ them rather than looking for alternatives? Because the moment you start looking for alternatives, what you're trying to do is to make sure that people think the alternative will work. And I don't know whether I've answered your question well, but I do know a few nurses in Malawi that were not able to get jobs outside Malawi because they're trained as what we call them. They've got diplomas, but it's a lower diploma. It's not a university diploma. So they can't leave Malawi. They'll get a job in Malawi, but they can't get a job in even in Namibia or South Africa. So it's they train for three years, but they do not get the qualifications of a state registered nurse. But it's a dollar. That's the question you're asking. Yes. So I think certainly it's to me, I think maybe traditional birth attendants would be that. But Kim wants to rescue me.
There's very little support for women during birth. And there's a lot of research now that even getting a birth companion is really important because generally the man does not accompany the woman. Sometimes it's the mother-in-law, sometimes it's the mother. But a lot of times women just labor and give birth alone. So even the concept of having somebody with you during the process is somewhat new in a lot of places. So there's a lot of work to even elevate that conversation. It's in the WHO's Safe Childbirth Checklist, whether or not you have a companion at birth. So I think it's still far from the concept of a doula. That would be even the next level, to have someone with you who was experienced.
So actually, Dr. Malata, thank you for your talk. Your question can maybe think of something. Is there home visitation in Malawi to try to decrease maternal mortality?
So a very good question, and I wish we had home visits, but they don't occur. Because I think the few midwives, nurses that are on the clinical side, their schedule at the moment. So it does happen, but it means maybe you have a special project, like I think Kim's project, they've done very well, probably reaching out to women when they go back home. Normally the women are supposed to be given an appointment to come back after they have given birth. And I do know as a midwife that we lose some, because if something happens, they will not come back and tell you that the woman died or the baby died. Yeah, but I do wish we had a very strong visiting system, because in that way we could perhaps handle some of the issues. On a study that Jeannie, Louis, and myself and others are doing in Africa on family planning, we are using a system where we're encouraging those who have used the family planning method, self-injection, to encourage other women. And we've noticed it's working. So it's not necessarily a health worker, but the health surveillance assistant will only just go and make sure that they're supporting the women. But it actually shows that if you allow women to do things whilst at home, so they can self-inject, they don't have to come to a clinic, the uptake is much higher. And I think it still relates to the question you've asked. So, but this is on our family planning research that we're doing. Thank you.
Thank you, everyone, for joining us today. What a pleasure it is to have Dr. Malata here talking about nursing and midwifery. She will be returning to the stage at IGHS, I think, Grand Rounds, right, Robert, on February 5th to talk about the program that she's co-building here at the Institute of Global Health Sciences. And we're so excited to also be there for that. If anybody would love to be a part of a very quick photo up at the front with Dr. Malata, we'd love to capture her and having you all here today. It's meant a lot to us to bring this community together. So thank you very much. And if you need extra